There are very few children in your caseloads over time for whom your actual educational intervention is dramatically different, whether you call them ultimately A, B, C, or D. In other words, as educators, we're not treating the child's label, we're treating their educational needs. Let me say that again. There are very few children for whom your actual educational input varies widely based on what we ultimately call them. Now, will we do something different with a deaf baby? Of course we will. Will we do something different with a severely visually challenged child? Of course we will. But the younger the age, the less important a label becomes. I want you to hear that. The younger the age, the less important the label becomes. I see some of you right. I want you to look here. Let me give you an example. Look here. Two children could come to your center for different reasons, vastly different reasons, at the same developmental level. Is that right? Different reasons, same level. Or they could come into your clinic for the same reason at different developmental levels. See, we're not treating their label. We're treating their educational needs. Now, I understand that a diagnosis can qualify child for services. It can be the entrance point from the medical community to the educational community in Turkey. I understand that. But there are very, very few children for whom your actual intervention is going to be dramatically different. Here's what the human development literature tells us. No test accurately predicts long-term performance for a child. No test. Let me take you into the psychology literature. If we take a group of typically developing children, they're just fine. All of their developmental milestones are occurring at the appropriate time. And we administer to those children, any one of us can do it, we administer to those children a comprehensive, global, meaning it covers all developmental domains. We administer to those children a comprehensive, norm-referenced assessment instrument. And we start that at 2 months of age. These are typically developing children, no risk. And every 6 months, we re-administer those tests, all the way till they're 5 years of age. With me? At what point in time along that continuum are those norm reference tests significantly correlated with performance at 5 years of age? In other words, what's the earliest age at which assessment can predict? Correlation is a statement of prediction. What's the earliest age at which assessment tests predict performance at 5? What is it? Anyone? It's 3. Now, follow my logic. If norm reference tests are not predictive for typically developing children until 3, how much less the predictive ability for the children you and I have in our caseloads? Who has typically developing children in their caseloads? I don't. You don't. You're not here because you're educating typically developing children. You're here because you're developing children who are not typically developing. So the basic rule is this: the younger the child, the less reliable your assessment results are. And it doesn't matter what your discipline is. It doesn't matter how good you think you are as an assessor. The younger the child, the less reliable your assessment results are. Why? Well, because time, spontaneous recovery of function, and maturation are on whose side? The child's side, not my side. And you see, that realization changes how we interact with caregivers. It changes our early communication with caregivers. Let me give you a little lesson in epidemiology. Very brief. Again, look here. Let's assume here's all the kids under 5 years of age. Here they are, that need some form or degree of special education. Okay? We can debate how we want to define this group, but here they are. Is this a homogeneous group of children? In other words, are they all the same? No. Tremendous diversity within that group. Having said that, there is a very helpful way to take this larger group of children and break it into two groups. And I want to give you those labels, and I want to give you the numbers. And I want to explain to you how it makes a difference in how we interact with parents. Okay, so here we are. Here's the larger group. We can break it into two. And it's not 50-50. One group of children that we can extract from the larger group, and this depends, the number I'm going to give you, depends on who you read in the pediatrics literature. One group of children we can extract from the larger group are those children we would refer to as established risk children. You know that terminology? Established risk. Let me give you the definition. It's very simple to understand. An established risk child is a child with a known condition for which developmental delay is part of that condition. Okay? Those are kids with any kind of a metabolic, chromosomal, genetic disorder for which delay is part of their condition. But that's only 15 to 25% of the children we see. And who does a good job of finding those? Who does a good job of very good job of finding the established risk condition? Children. The medical community does. I've been in delivery rooms all over the world. I lived for 6 months in South Africa. I watched babies being born with a mother squatting behind a bush, in the bush, literally. You don't have to be a geneticist to look at a newborn within a minute of delivery and say, there is a significant pattern of dysmorphology here that is suggestive of a genetic condition. You may not know what that syndrome is, but in the delivery room you can look at a baby and say, something is dramatically different here. That's only 15 to 25% of the kids we see. Okay, and the medical community does a good job of picking those up. By far the larger group of children are those children we would refer to as at-risk children. That's 75 to 85% of the children we see. An at-risk child is a child who, because of any one of a number of environmental and or biologic conditions, is at greater risk for later patterns of delay. That's the category of children that the medical community does not do a good job of finding, because they don't fit the dysmorphic pattern, they don't fit the pathology pattern that an established risk child would fit. Let me tell you how that makes a difference. The story I'll describe for you right now would not happen for me on the same day. It would happen in the same month. Let's assume that next week I make my rounds in our neonatal intensive care nursery. And a child with Down syndrome has been born. He's 2 days old. He's healthy enough to go home. And on the day, is that established risk or at risk? That's an established risk condition. On the day he's going home, mother and or father says this to me, Dr. Rossetti, how do you think he's going to do long term? What are you going to tell him? By the way, have I got a gun? One is right here. Yeah. What are you going to tell him? On day one, what are you going to tell him? So that's an established risk condition now. So it is entirely appropriate to tell that mother on that day, and this is the exact wording I use, your son or your daughter is going to need some specialized educational intervention throughout his educational career. I can tell her that at 2 days of age because developmental delay is part of Down syndrome. So there's any one of a number of syndromes, genetically linked syndromes. I do know you well enough to know that you were not, it's not your fault, you were not trained well in the area of genetics. I think early interventionists should be trained in the area of genetics. Not medical genetics, but clinical genetics. If we had another day, I would walk you through that. It's a simple thing to do. Now, I've just talked to this mother of a little child with Down syndrome. But let's assume 30 minutes later, another mother comes to me. And her child is not a child with an established risk condition. He's at risk. Okay? Perhaps he has several environmental and or biologic risk factors. Let me explain. I'll give you an example. Put in your mind what it's like when you peel an onion. Forget what it does to your eyes. That onion has a layer after a layer after a layer. Right? Here's an at-risk mother. This would be a mother I would see. Okay, 15-year-old mother. That's the core. Who got, here's another layer, minimal prenatal care. Who comes from an impoverished, poor family. Who has very poor parenting skills. Whose baby was born at 750 grams. Okay, you see what I've layered here? Biology, environment, biology. That's 75% of the babies. They're out there. It may not be 75% of the children you see, but it's 75% of the total population. Let's assume she comes to me and says, we're going home. Let's say her baby's been in the hospital for 6 weeks. We're going home. How do you think he's going to do? Can I tell her the same thing that I told the mother of the established risk child? I can't. I can't. See, what I can tell that mother is, Mom, Dad, our experience has shown us that babies that have been as sick as yours need to be followed carefully so that we can monitor his development and provide any degree of specialized education that's needed. Now, there is a phrase that I would encourage you to use with every family you see. Every family you see, you can use this phrase. By the way, I just pulled the trigger twice, didn't I? One gun for the established risk, a different one for the at-risk. After I pull the trigger, I always say this. Always say this. But I guarantee you, Mother, I guarantee you, Father, he's going to grow, he's going to learn, and he's going to change. You are safe in telling every family, no matter how profoundly involved a child is, that he's going to change. All children change unless they're in a vegetative coma. All children will change over time. Okay? Now, I want to pause here, and we'll do our best if you have a question. But I'm going to shift topics here. I told you we only have 3 hours. It goes very, very quickly. Do you have a question? Someone may have to translate for me. Anybody at all? Please.
Speaking Turkish. Şimdi erken risk dönemi olduğunu duydun mu? Tercüme için. Tercüme ediyorum. Erken dönem risklerin fark edilmesi üzerinde durdunuz. Tamam.
I'll need it in English.
Kulakta oraya verin. Siz benim. Peki, tamam.
Yes.
Erken risk saptandığında şu tür bir sorunla da karşılaşabiliyoruz. Çünkü örneğin daha şizofreni için düşünelim. Şizofrenideki at-risk population'ın tanımlanması aynı zamanda gereksiz tedavi ihtimalini de getiriyor. Gereksiz tedavi ihtimali bu üreten bebeklerde onunla nasıl dengelenebilir? O konuda bir yorum yapabilir misiniz?
Yeah. That's an extremely good question. And I wish I could give you a data-based answer. Your clinical skills can determine the difference between them. Your clinical skills and your experience. You will learn those family situations and the pattern of behavior in different children that will ethically drive you to recommend treatment a little bit earlier for one child and perhaps a little bit later for another child. Even though earlier is better for that particular category of children, I trust your clinical instincts. I do. I trust your clinical instincts. If I have to choose between believing a test or believing you, I will believe you every time. And I've not met you before. But I trust your clinical instincts. See, one of the problems with assessment instruments is this. We tend to hide behind them. Okay, we tend to let the test results drive us. And that is that diagnostic model that I referred to earlier. Again, I would free you from that if I can. As educators, diagnosis does not dictate treatment. Having said that, if it's a choice between test results, developmental test results, and your clinical experience, I trust your clinical experience. Let me give you a definition. I want to give you a definition of an assessment instrument. I think this will help. This is something I wrote about 15 years ago. Of anything I've ever written, this is the most quoted thing I've ever written. This is a definition of a test. Okay? This is how I would define a test. I would define a test as any activity, either formal, through the use of norm-referenced, standardized criteria, or informal, through the use of developmental profiles or checklists that's designed to elicit accurate and reliable samples of behavior upon which inferences are made. Now, the three key parts to that definition I've highlighted in red. Assessment is any activity. And somewhere along the line, we got the idea that assessment means giving a test. There is a place for tests. Don't misunderstand me. But let me give you my definition of a test. This is as simple as I can make it, I believe. A test is simply a system for collecting and analyzing samples of behavior. That's all a test is. There are good tests, there are bad tests. But all the test is designed to do is help you systematically observe behaviors. That's all a test is. It's nothing more than that. I think we place too much emphasis on it. But look at the second part of the test that's highlighted, that elicits accurate and reliable samples of behavior. Okay? Let me give you an example. Let's assume that I took your picture when you walked in the door. It's a snapshot. And you're crying when you came in. Would it be fair of me to say, what is wrong with this lady? She's always crying. Would that be fair? Would not be fair. See, there may be circumstances that related to her tears when she walked in, but for me to generalize a snapshot when she walked in with tears to suggest that this woman has problems because she's always crying, that would be very unfair. That's the danger with tests. All we have access to is a snapshot. And because of that, we can't make pronouncements about the long-term potential for a child. It is what I suggested earlier. The younger the child, the less reliable your test results are. Because everything is on the child's side. Okay? Here's a question I would strongly encourage you to ask every time you assess a child. Every time you assess a child, ask the caregiver this question. And I would tell you as well, I never separate mothers and children when I'm assessing, ever. There's just simply too much to learn with having the mother and or the father in the room. Always ask this question. This is how I word it. I just finished the assessment, and I would say to her, is this about right? Does this reflect what he or she can do? Now, they will give you one of three answers. They will say, yes, that's about right. That's about right. Write what she says down. Or they will say, he does a whole lot more than that at home. He does much, much more than that. And you must follow that up with saying, tell me what that means. Tell me what he does at home that I was unable to get from him right now. Or he or she will say, I had no idea he could do those things. And if you're good at what you do, you will get a lot of those answers. See, it's always good for me when I assess a baby when mother says, I did not know he could do those things. Yeah, it means I've gotten some things out of him that his mother had not seen before. Let me tell you what the pediatrics literature says about mother's observation. This is very current literature. Mothers have consistently demonstrated themselves to be reliable and accurate, here's the key word, describers of their children's behavior. So when a mother tells you her child can or can't do something, she's right. Okay. Having said that, at the same time they are accurate describers of their child's behavior, they are very poor interpreters of what that behavior means. That's your job. You're the child development specialist. You interpret what that means. There was an article published, I want you to hear this number now. There was an article published in the 2008 Journal of Pediatrics that said this. It's a long, complicated article. I'll give you the part of it that really sticks out. 2008 Journal of Pediatrics, I have that correct, yes. 75% of the time, when a mother expresses concern about her child's development, she's right. 75% of the time. She may not understand it, okay, but she's right. Now, the results of that study were so powerful that the American Academy of Pediatrics in 2010 issued the following position statement, and they don't do this a lot. They said this, that physicians, developmental specialists, should consider parental report to be as reliable and accurate as formal developmental screening. That's a very important statement. Okay? Developmental specialists in the medical community and the medical community should consider parental report to be as reliable and valid as formal developmental screening. So when a mother says, I don't think he's doing what he should be doing for his age, believe her. Believe her. You can assess, certainly, and you might prove her wrong, okay, as you gather samples of behavior. Now, we talked about the snapshot. How can I demonstrate? Remember now, I just took a snapshot and she's crying and I'm thinking there's something wrong with this person. She cries all the time. How can I demonstrate that that would be untrue? Well, how about if I take a snapshot today, and I take one tomorrow, and I take one a month from now, and 3 months after that, and of those 4 or 5 snapshots, this is the only time she was crying. See, what does that demonstrate for you? That demonstrates for you the need for what we would refer to as serial assessment, please. That demonstrates what I would refer to as the need for serial assessment. This is crucially important and predictive, what I'm going to describe for you right now. Let me define it. I would define serial assessment as regular assessments over regular periods of time. So if I want to prove that she's not crying all the time, I'm going to take a snapshot today, and 3 months from now, and 3 months after that, and maybe 3 months after that. Serial assessment. regular assessments over regular intervals of time. What does that do for you? What does that do for you? All right, now listen how I word this. What is predictive of a child's performance long term will never be single tests at any point in time, but rather the pattern or the rate of change developmentally that a child demonstrates over time. Okay, did I say that? Well, yeah, I got that right. I have to check myself. The pattern of developmental change that a child makes over time is predictive. Now, here's what we see in children, particularly under about 7 years of age. We will see one of 3 different patterns of developmental change. This is well established in literature. I've written a lot about this. We'll see one of 3 different patterns of change. I'm going to demonstrate them for you. And remember now, serial assessment is similar to multiple photographs. Okay? You need to look here now as I demonstrate. Let's let this hand represent age-appropriate performance. So this child is 2 weeks, 2 months, 2 years, 4 years, 6 years. This is what he should be doing on this age. Okay? And you assess him. And he does this. He should have done this. He did this. All you know, depending on which instrument you use, is that there's a gap here. And that gap is described in multiple different ways, depending on the test you use. Percentiles, quartiles, developmental indicators, all tests do it differently. But the simple reality is, he should have done this, he did this. This gap tells you nothing, predictively. But what happens to this gap over time tells you everything about that child. And you'll never know what happens to this gap over time unless you engage in serial assessment. There are 3 patterns. Watch what happens. This is what he should have done. This is what he did. Now, is this hand going to stay the same? No, he's a day older, and a day older, and a day older. We know what typical child development across developmental domains should look like. So here's what he should have done, here's what he did, and over time, watch the gap, because both hands are going to move. Watch the gap. What's happening to the gap? It's staying the same. Okay, I would call that typical atypical development. Typical atypical development. In other words, the child is displaying a typical pattern of developmental progression, but it's all delayed. It stays the same. Okay, that's one pattern. Okay, that is a vastly different child than pattern number 2. Here's pattern number 2. This is what the child should be doing. This is what the child did. Now both hands are going to move, but watch what happens to the gap. What's happening? The gap is widening. In other words, the difference between what he should be doing and what he is doing widens over time. That is always a bad sign. Always. Always a bad sign. Why? Why is that a bad sign? Not because the gap is widening. Make it even simpler than that. It's a bad sign because it goes against nature. If you know anything about neonatology, if you know anything about embryologic development, if you know anything about early, even prenatal development, I published a number of articles on prenatal stuff, you know that infants come into the world, healthy babies come into the world insatiable to consume it. They are insatiably hungry for the world. That's what nature built into them. You don't have to do anything special. Just keep a baby healthy and give him exposure. And what neurology and nature built into him takes over. If I'm talking faster, it's because this is the thing I get most excited about. Babies come into the world uniquely predisposed to consume it. They are insatiable consumers. I'm going to do a parenthesis here now. How would you define cognitive development? If you come with me to different parts of the world, there's vastly different meanings. How would you define cognitive development? Let me give you the simplest definition I know. Cognitive development is nothing more than making sense of the world. That's cognitive development. Making sense of the world. And in order for a child to make sense of the world, there's only two things they need. There's only two things a child needs in order to make sense of the world. You might be more familiar with the terms nature, nurture, and there's nothing wrong with those terms. I don't use those terms. Okay? In order for a child to make sense of the world, what they need is opportunity and ability. That's it. That is all a baby needs. Opportunity and ability. So in other words, opportunity relates to nurture. Ability relates to nature. So if we give a healthy baby appropriate opportunity and ability, their inborn insatiable desire to make sense of the world kicks in. It's awesome to watch. I used to do infant gaze time research years ago, and we would gaze what babies, we would measure what babies would gaze at. Babies can distinguish between their mothers from 2 hours after birth, their mother's scent. It's incredible. I have to share this one with you because I still get excited with it. One of my doctoral students a number of years ago came to me and she said, here's how I want to do my dissertation. She had been reading the research as to how babies responded in utero to different sounds that were played to the mother. So there was literature out there. They were playing different noises to the mother. What does it do to the baby's heart rate? And she said, I don't want to do it that way. I want to play different stimuli directly to the baby. How are we going to do that? Well, I'm on the medical school faculty, so I went to the chief of obstetrics, who was a good friend of mine, and I said, here's what we want to do. We want you to bring in 12 women who are at 38 weeks or beyond in their pregnancy, which means their term. The World Health Organization continues to define maturity as 38, 39, and 40 weeks. So these mothers are at term, okay? And what we did is we brought these mothers, 12 of them, into a quiet, darkened room. We played all of them the same quiet music. He came in and felt mom's belly to find where the fetal head was. We put a microphone on mom's belly, right where the baby's head was, and a fetal heart monitor. And what we did is we got a baseline heart rate, and then we played via this microphone on mom's belly 9 different syllables with a male voice. So we got a baseline heart rate, we played a syllable, we watched what it did to the heart rate. We turned the syllable off, we waited for heart rate to go back to baseline. We waited 2 minutes, we played another syllable. It's fascinating. There was one syllable that had a statistically significantly faster heart rate than any of the other syllables we played. What was that syllable? Think. You'll know it. Somebody said it. You'll know it. Mom. Mom. Now think. See, I share that with some of my neonatology colleagues, and they say to me, are you suggesting that there's something in the pre-wiring of babies that drives them to respond to ma in a way reflected by heart rate that differentiates from any other syllables? You know my response to that is? What is so hard to believe about that? See? What sound begins the word that denotes the female parent across the globe? What sound? Followed by a wide open vowel. See, frankly, if you're into linguistics, historical linguistics, you can legitimately ask the question, what came first? The word or the baby's predisposition to it? There's no way to answer that question. That's how uniquely wired babies are when they come into the world. So, When that gap widens, it goes against nature. And when I see that gap widen, that's when I pull the trigger. I would sit down with a mother. Here's how I would word it. Remember now, perhaps you've been seeing this child over the course of 12 to 15 months. You're assessing and you're providing treatment. The gap is widening. I would say this, mother, I'm not suggesting to you anything I always use the word we. I'm not suggesting to you anything we don't already know when I suggest to you that this is a long-term educational issue. Okay? And then I instantly follow that up with this phrase, but let me tell you what we use. We again, let me tell you what we can do about it. The we engages her. And it tells her that you want to partner with her in that process. Now, you've got typical, atypical development. You've got atypical development. There's one more pattern. This is the pattern you want to see. This is what the child should be doing. This is what the child did. And over time, this is what you observe. What's happening to the gap? It's closing. I would refer to that as catch-up growth. Catch-up growth. That's where the child's rate of developmental skill mastery over time closes the gap between what he is doing and what he should be doing. That's what you want to see. I talked with some mothers this morning at the center that I visited whose children have demonstrated catch-up growth in the past 12 months. That's a good thing. That's a very, very good thing. Okay? Help me out time-wise now. I read you well. I read audiences. I think we'll take a break. Let's take about a 10-minute break right now, and then we'll come back. I'm reading you. I want you to stay awake. That contributes the most to successful performance in school is that of communication skills. I worded it this way. Those children that possess an age-appropriate system of communication when they enter school generally do better than those that do not. And so any system of intervention, any program, any center must have at its core the promoting of a child's communication skills. What I'm going to do now is walk you through a model of promoting a child's communication skills, a model that in some ways begins at birth. Now, let me tell you how I did this. In preparation for one of the books that we did, I gave my graduate students an assignment. They hate this when I do it, but I do it anyway. I told them, I want you to take all summer, and I want you to review very, very carefully the world's literature. And I want you to come back from that with some checkpoints, some bullet points that describe in short statements how children develop age-appropriate communication skills. You follow? Now, if you think that's an easy assignment, try it. They came back, I believe, with 85 or so different bullet points. See, I wanted to take those bullet points and from them construct a model, a paradigm, a blueprint for facilitating a child's communication skills. We took those 80 or so and we condensed them down to what you see here. And even in addition to this, there are several that I need to add. Let me give you some facts. I don't have time to develop them. Let me give you some facts from the human development literature. You can just take these down if you choose. These are established facts. Are you ready? Prior to 4 to 6, now we're going to talk typically developing children. Okay. Prior to 4 to 7 months of age, okay, the child is the primary initiator of communicative exchanges. Prior to 4 to 7 months of age, the child is the primary initiator of communicative exchanges. However, this is very important, the adult can keep that exchange going. So prior to 4 to 7 months of age, the child is the primary initiator. After 4 to 7 months of age, the adult can keep it going. Okay? After 4 to 7 months of age, the child and the adult initiate and prolong equally. Now you're going to see what this means as we talk about facilitating the child's communication skills in just a moment. Let me do that again. Prior to 4 to 7 months of age, the child is the primary initiator of communicative exchanges, but the adult can keep it going. Do you see the implication to that? Who has to teach mother how to identify the child's initiations? And who has to teach mother how to keep that exchange going? You do. You do. After 4 to 7 months of age, the child and the adult can initiate and prolong equally. That's a fact from the human development literature. Let me give you another fact. Prior to 4 to 7 months of age, 7 months, if you know anything about pediatric neurology, is a watershed mark. There's a lot of neurology that kicks in and manifests itself in physical attributes by 7 months. There's a lot of stuff that has to happen. Okay. Prior to 4 to 7 months of age, babies are primarily interested in faces. That's what nature built into them. Prior to 4 to 7 months of age, if you measure an infant's voluntary gaze time, they're primarily interested in faces. After 4 to 7 months of age, babies are primarily interested in objects. Again, that has clinical implications for facilitating a child's skill. You tell me from a motor perspective, what happens in the 4 to 7 month range? Two things. What happens? One primary thing, but sometimes two for some kids. What happens? What can he or she do by 4 to 7 months of age, a typically developing child? Sit and reach and grasp. So at the point at which the child develops, less so sitting, but certainly reach and grasp, the point at which a typically developing child begins to reach and grasp is the point at which their interest shifts from faces to objects. Okay? Now, keep that in mind, because that has a direct clinical implication for a premature child or a child that has risk factors early on. Because what you want to tell mother is this. Here's a treatment statement. Get your face in the baby's face. See, that's what babies are wired to gaze at early. Okay? And that's what, once the child begins to reach and grasp, they're no longer primarily interested in faces. Once the child makes that transition, then you can teach mothers to follow that child's interest in the objects that it will reach for. You know what it's like to try and get eye contact with a 2.5-month-old. If they don't want to do it, they will not do it. Is that right? But if they do want eye contact, they'll maintain it for a prolonged period of time. So we have to teach our caregivers to take advantage of that. Okay. Now, let me give you some other facts from the human development literature. When you examine what mothers say to their babies under 7 months of age,